Okay, welcome everyone. I see people are trickling in. Invitation to introduce yourself in the chat. And if you would like to put your name, your organization, and your role, just to give us a sense of who's in the room with us today. And we have a great panel. So without further ado, I think we'll get the webinar started. So welcome everyone. And we will start the presentation in a good way with a land acknowledgement. So we recognize that the work of the Alliance for Healthier Communities and Alliance members takes place across what is now called Ontario, on traditional territories of the Indigenous people who have lived here since time immemorial and have deep connections to these lands. We further acknowledge that Ontario is covered by 46 treaties, agreements, and land purchases, as well as unceded territories. We are grateful for the opportunity to live, meet, and work on this territory. Ontario continues to be home to vibrant, diverse Indigenous communities who have distinct and specific histories and needs, as well as constitutionally protected and treaty rights. We honor this diversity and respect the knowledge, leadership, and governance frameworks within Indigenous communities. In recognition of this, we commit to building allyship relationships with First Nations, Inuit, and Métis peoples in order to enhance our knowledge and appreciation of the many histories and voices within Ontario. We also commit to sharing and upholding responsibilities to all who now live on these lands, the land itself, and the resources that make our lives possible. And I myself am zooming in today from Ottawa, where I work on the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation, whose presence here reaches back to time immemorial. We recognize the Algonquins as the customary keepers and defenders of the Ottawa River watershed and its tributaries. We honor their long history of welcoming many nations to this beautiful territory and uphold and uplift the voice and values of our host nation. If you're just joining us, I will invite you to introduce yourself in the chat, your name, your occupation, where you're zooming from, and your role, just so we have a sense of who's in the room with us today. And just a little Zoom housekeeping. In case Zoom is a new experience for you, here are some housekeeping that can support you through this webinar. If you do have questions, technical questions, we have some folks monitoring the chat that can support you, so feel free to ask questions. I'll move on to the next slide. We have an amazing panel here today to talk about social prescribing and primary care attachment. The Alliance's own Dr. Jennifer Rayner, who's the Director of Research and Policy, will go first with a presentation. Dr. Ritika Goel, who's a family physician, we're really honored to have here with us today. Allison Hewitt is a registered nurse specializing in geriatrics at Centretown Community Health Center in Ottawa. And Margo Reilly is the executive director at Windsor Family Health Team. So a really great panel with really different perspectives and sharing how they use social prescribing in their work or how it could be used. And then I'll just maybe give a brief introduction of I'm sure many of you are familiar with social prescribing, but I'll just give a little brief introduction about how health equity focused social prescribing, how we do it at the Alliance for Healthier Communities. So just a little slide on some of our foundational elements, the way we work at the Alliance. So we use this health equity charter, which is oriented to advancing health equity through a human rights and social justice approach and driving change at all levels. So systems, policies, as well as organizational and individual practices. And then our second set of foundational documents are our model of health and well-being, and our Indigenous-led primary healthcare organizations use the holistic model of health and well-being. So this guides all of our work, including the social prescribing work. And then I'll just give you a snapshot of our history of social prescribing at the Alliance and where we are at today. So it all started back in 2018 We were so young and carefree then when we implemented the social prescribing pilot based on some of the models that were coming out of the UK. And we implemented that with 11 different CHCs in different settings across Ontario. And that's when we saw that this could really work in our setting. Then came the Links to Wellbeing, social prescribing for older adults. And that is a partnership with the Older Adult Centers Association of Ontario. And we are building seamless referrals from health settings to community settings, including those that we can find at seniors active living centers across Ontario. And that project continues today, and we are always open to working with new partners to so that's social prescribing for older adults. And then came the social prescribing for better mental health project, which was an 18-month project funded by the Public Health Agency of Canada. Worked with 28 different sites to implement social prescribing to build pathways or improve pathways for social prescribing. And out of that work came our quality improvement, healthcare coaching way of working to build sustainability with social prescribing sites. And we also built a lot of resources and tools which are shared. And out of that also came our online learning modules, which we'll talk a bit more about later on. And then finally, the Black Focus social prescribing, which is where we designed a culturally affirming social prescribing to improve healthcare experiences and healthcare outcomes for Black people living in Ontario. And we worked with 4 sites to implement that, and we are hoping to spread and scale that work. And I think one other piece I'll just add briefly here that is unique perhaps to Alliance members is we have a shared EMR, and we can have some standard ways of inputting and measuring social prescribing in our work. So without further ado, there's a great panel here, and I'm eager to hear what they have to say. So I will move the mic over to our first speaker, Dr. Jennifer Rayner.
Thanks, Natasha. So if we go to the next slide, thanks. So the Alliance strongly believes that health promotion and social prescribing are really integral parts of comprehensive primary health care. As you know, we are in an amazing time with incredible investments in primary care, and the Alliance has put forward a vision where social prescribing is central to ensuring that our clients and communities have the best healthcare possible. So before I get to that vision, I want to go back a little bit and explain why we've been thinking so big. So as you've probably heard, for the last few years, we've really been hearing about a problem with primary care access and attachment. And in Ontario alone, 2.3 million people are without a primary care provider. And so when I say that, I mean a physician or nurse practitioner. And so what the government has done in response to that is they've invested $1.8 billion to be spent over the next 4 years. So primary care throughout Ontario is really being challenged to serve higher numbers of unattached people really quickly. New teams are being established, and our goal is that all teams work to full scope. But we think about teams in a really large way. So you're going to hear about how we've sort of thought about this and are really hoping to our Alliance members and people all across Ontario will embrace this approach because we've got really ambitious targets. So just for example, the teams that were just funded have to see 300,000 people by March 31st, 2025. There's a new set of teams that will be funded that their goal will be to serve 500,000 people. So they're just like, the goal is to have 2.3 million people attached in the next 4 years. We need to do things differently because we know that we can't keep doing the same thing. We need to try new things. We need to innovate. We need to, work with people differently. We need to have a population approach. And so hopefully this vision will sort of demonstrate how we're hoping people can start to think differently. So next slide, please. So the Alliance has pulled together this model that may help teams and providers with their planning. So this model is built from evidence and research right across the world into what really works for people, especially those people who have traditionally faced barriers in the health system. So from those that sort of work with the Alliance members or have a determinants of health or equity-based approach, this isn't going to seem too different. But what we tried to do is gather a bunch of best practices to create this vision for a neighborhood health home. Because from our vantage point, we believe that the redesign must have an equity lens and must be grounded in community. So the model we're proposing is robust. It's built on 6 pillars, including that it be interprofessional, collaborative primary health care. It should have community governance, so have the folks whose health is at stake be responsible for some of the planning and engagement, be population-based, so not just focused on the people who are coming through the clinic doors, but those that are within our community. It should have a strong data foundation, a focus on equity and determinants of health, and be both accountable and efficient. So next slide. So this vision is the neighborhood health home. What we hope to see is that they're nestled within neighborhoods, serving people within that region or a large neighborhood. So the neighborhood health home would ensure that people have barrier-free access to interprofessional teams, health promotion, social prescribing, and community supports. So like I mentioned on the earlier slide, our vision is that communities are responsible for the governance and that they're actually decision makers for what is needed in their community. Along with community governance, this includes a community-centered approach to co-design with communities to really ensure a tailored based approach for the services that are being planned. So the neighborhood health home is a population-based approach that is grounded in health equity. And we envision that the entire community is part of this neighborhood, not just, again, those folks that walk through the clinic doors. And that the goal would be to build on existing team-based models where possible and not create new ones. But we have collaborations of providers that are all working together to full scope to ensure all people in that community can receive the care when it's needed, seamlessly linked across providers, teams, and settings. So this includes all sorts of providers working together, including physicians and nurse practitioners, link workers, community health workers, social workers, peer navigators. And there's these things called primary care networks, and we know that they're really important to help design, and they're a strong building block in the oversight of these neighborhood health homes, because we want to ensure that primary care providers are sort of involved as well in every step along the way to create these. So what the neighborhood health home really is it's just basically a hub and spoke model. So again, many of you have implemented things like this already, and it's already being actualized a lot, both before these EOIs are being funded, because you're going to hear from Margo, and she's got a bit of a hub and spoke model. So there's lots of people doing this already, and there's lots of people rolling it out now. So we believe the hub will be an existing interprofessional team-based primary care organization, and this provides lots of benefits, such as accountable leadership, community governance, that equity approach, and some back office support, including data, learning, quality improvement. All of the spokes are the primary care providers within the primary care network. Or they might be specialized primary health care organizations, such as those providing gender-affirming care or newcomer care. But our goal is to ensure that every primary care provider is part of this team, regardless of location. So it's not a referral, but we're just working together to serve a population in this sort of hub and spoke model. And like I said, similar models have been developed with really strong results. The next slide. So this model, like I mentioned, and I've talked about this a few times, has 6 pillars, none of which will be surprising to you. And I've gone through them a little bit, but I just wanted to really focus in on where social prescribing fits and is foundational to this model. So you can see that we feel it's really important for it to be interprofessional and collaborative, with a population-based approach, with a strong focus on equity and determinants of health, which I believe is social prescribing in a nutshell. So just to the next slide. So, I mean, why do we think this is important? I think we must think beyond primary care when we think about attachment. And there's a few reasons for this. Bottom line is those folks need to be attached to a primary care provider, but we know what makes people sick, and these situations are sometimes not best treated by a physician or nurse practitioner. We know that having teams, including health promotion, community health workers, and link workers, can alleviate pressure on physicians and nurse practitioners to free up space in their scheduler. And ultimately, I think there's no wrong door to attachment. We've heard amazing case examples of people who meet their link worker or their community nurse, And then they come into, they build trust, they build relationships, they get what they need addressed at that time, and then they get attached to a primary care provider. So I see that as being like no wrong door to attachment. It just might take a different path, but those folks are still being attached. So next slide. Finally, I just wanted to emphasize the role of health promotion and link workers within the hub to really accomplish what we've just spoke about. And as I've said a few times, we believe these roles are integral, and we're advocating that they be part of every hub and be the link between primary care, social, and community supports. So ultimately, the hub, which again is supporting this population, would include health promotion and chronic disease management activities that again support the whole community. They'll have link workers and community health workers, again, to support primary care providers and work closely with teams to ensure that care is provided by the most appropriate person, and that the hub can address all of the client's social needs. And we recognize this requires time and resources that a physician and nurse practitioner probably don't have. The link workers can spend time with clients, really addressing all their needs and concerns, and ensure that referrals and supports are streamlined and supported. And again, this is supported by research that suggests that link workers can increase primary care capacity and reduce emergency room visits. So we've just entered the next round of expressions of interest for the expansion and continue to advocate for this model. And as I said, so many people are writing their EOIs to sort of describe this sort of model. Most of you probably know that the deadline for the next EOI is in a few weeks. So on the next slide, there's a bunch of resources. We can just go to that can really help support your centers and regions in completing this EOI. So one, we've got a toolkit that includes lots of amazing case examples if you need to have your imagination sparked. We've got our vision paper and an introductory webinar. We've got a template, EOI proposal template that really basically has some answers to all the questions on the EOI. Then we also encourage you to use the OHT data, and we've got examples of collaboration and partnership letters. So please reach out if you have any questions, but all of those are hyperlinked, and when you get the presentation, you can have a look at some of the tools and resources that I've provided. So thanks so much for the time, and I'll turn it over to the next speaker. Thank you.
Thank you so much. That was fantastic. So we'll just take a moment to gather our breath and bring up the slides for our next speaker, Dr. Ritika Goel, and just give me a moment to pull up the slides here. Here they come. Okay, please take it away.
Thanks so much. So my name is Ritika. I'm a family doctor at the St. Mike's Hospital Academic Family Health Team in Toronto, coming from Treaty 13 territory today. So glad to be able to be here as part of this really important conversation. Next slide. So any opportunity I get, I always like to insert this context, because particularly working, in clinical medicine, in primary care, it's so important. We are so well situated, at the front lines of where health and social determinants intersect, because people are trying to access primary care. They've got a certain idea about what that looks like, and yet we constantly have so many opportunities to be able to do more for people and to really address their needs, which they may not always actually see as being something that you raise with your primary care provider. So this is the original WHO conceptual framework for action on the social determinants of health. And what I love about this is it talks not just about the social determinants of health, but upstream of that, it talks about the social determinants of health inequities, also known as the structural determinants of health. And it starts to talk kind of beyond some of those social factors that we think about, like race and education and occupation and income, and really talk about the broader kind of the why, even of SDOH, which we think of as the why of clinical presentations, but the why being the socioeconomic and political context. So thinking about our policies, social, public, culture, and societal values. Next slide. And then, of course, going one step further back, this is the ultimate why of the why. I like to always bring a lens of systemic oppression to any of this work. So thinking about what's happening from a broader perspective, what's happening at an individual level, a systemic level, and essentially how are we seeing the broader power structures in society play out to actually shape that first column in the WHO Commission's concept of SDOH. So how does our history, how do power structures more broadly in society shape the governance and the policies? You know, why are we where we are? Why are we who we are? Why are we doing what we're doing? And then how are we kind of shifting that and trying to mitigate the inequities that have been baked into the system that often we are also very much taught to perpetuate. Next slide. So I like that question, or the title of this presentation really is thinking about social prescribing for primary care attachment. And I thought about it in the context of having worked in a number of settings. So I work now primarily at a family health team, but I've worked in community health centers, I've worked at shelters and drop-in centers. And really my clinical focus throughout my entire career has been serving marginalized communities, whether that's people who are unhoused, folks who use drugs, folks who are trans and non-binary, folks who are undocumented and uninsured. And what I was coming back to over and over is that we really kind of have three main points of intervention when we think about what we can do in primary care. There's before the attachment, and then there's those kind of critical, anyone here who's a clinician knows there's those critical first few visits where you kind of either connect with someone and are able to successfully attach them, or you don't. And thinking about what we do in those visits is really important. And then there's the ongoing care and kind of how we're responsive to people's needs. So the piece before attachment, the community services that are offered by any primary care model are so important here, or the model even kind of co-located within social services. So I think, for example, of Inner City Health Associates in Toronto, which has family doctors and psychiatrists working out of community agencies. So I used to work at Sistering, which is a women's drop-in, and the reason why people would come and see me for primary care is not because they know anything about me, it's because they trust the agency that they're going to. Similarly, in community health centers where I've worked, the reason people would come and see me is because they had been coming downstairs forever to get their safe supplies, right? They had been coming to access programs. They had been coming to just have a safe place to be and a place where they felt loved and in community. And then eventually someone said, "Hey, do you have a doctor or do you have a primary care provider? Maybe you should go upstairs and check that out." So I think we really can't we really can't underestimate or undercall the impact of all of those things that any primary care facility is doing beyond the actual primary care, because particularly for marginalized people, that's often what is actually bringing them in the door. And then the actual support with attachment. So the beauty of having link workers, or in our case, we have link workers. We also have Indigenous wellness specialists who are not required to only see people that are currently rostered to our care, right? They can actually be in the community. They can be building those relationships, or having pathways through existing service agencies, having informal pathways, like I have many case managers, for example, who know that they can send me information for someone who's unattached, or I have existing patients who will bring me a friend or bring me a partner or bring me their child or their spouse, etc. And kind of a lot of those informal pathways are so critical to attachment because they're built on existing trust. And so a lot of what we're talking about with social prescribing is also how do we actually build trust with people? And so I come to those first few visits, the critical kind of ability to connect with people and really show them that we are going to hear them and we're going to really address the needs that they're raising. So in those first few visits, making sure that you're assessing the needs in a broader perspective. So, asking people about their medical symptoms, of course, but also making sure that we're really assessing people's social context. And I'll get into that a little bit more with some tools that can be used. And then once you have a sense of all of their needs, which is their medical needs, but also kind of what's happening in terms of their social needs, then prioritizing interventions based on the patient's needs, but also their preferences. So for me, this often looks like in the first visit, asking people, what is your priority? What do you want to make sure? Is there something that's feeling really urgent for you that you want to make sure we address today? And that might be their back pain that they haven't been able to talk about for 10 years, or it might be the fact that they don't have a place to stay. A piece that can be really important here is that we have to do education with our patients sometimes around the fact that these are issues you actually do talk to your primary care provider about, because many people have learned or been socialized to think that social issues are not something you raise with your family doctor. So again, kind of signaling over and over that you want to know about people's broader lives and their context, and not only do you want to know about it, but you have actual practical things that you can do, whether that's referring internally through your team, or it's referring externally through community agencies, or whether it's actual things that you can intervene in yourself, for example, helping people access income supports. And then in terms of the ongoing care, I think making sure, as I said, communicating that social issues are a part of your ongoing care. This is a place where people can come and they can talk about everything. And then using social interventions both proactively and responsively. So for me, this means, being aware of which of my patients are on OW or ODSP, and whether or not we have made sure that they're getting access to the special diet fund, or transportation money, or have we applied for a disability tax credit. So those are things I will proactively actually ask people about, because they may not know the programs exist. And then, of course, also responsively providing supports and referrals as needed. And then, of course, that biggest piece, which is the ongoing relationship and trust, not just in yourself, but also in the team. There's, of course, a ton of borrowed trust that happens once you've established a good relationship with someone. And there's lots of ways, whether it's warm handovers or kind of vouching for other people on your team, that can often help build that broader relationship. Next slide. So this is a whirlwind, but folks may have come across a social history tool called the If It Helps mnemonic. And this is essentially just a way to organize kind of our thoughts around what, potential areas of social context we both may want to assess, and also where we could potentially intervene. Next slide. You can just click through the points here so they come up. Yeah, so just some tips that I use for myself. The social history section of the EMR is critically important. Making a stamp with the social history headings, whether that's If It Helps or if it's some other version that you've got, but having that there so that you're constantly cued to update that information, just like we update the past medical history and family history and medications as we get different information. Standardly asking extensively about social context in the first visit, and kind of letting people know, again, signaling. So I might say something like, I always find it helpful to know a bit more about what's going on in people's lives, so I know how best to help. So both explaining why I'm asking, because often people, might otherwise get their backs up, and also kind of constantly, continuously demonstrating that I'm going to do something actually useful with that information. So they're not just having to disclose personal things for no good reason. Next slide. And you can click through. So this is just an example of how you might use, like what the social history section might look like for a particular person. If you're kind of, yeah, keep going, just click through. Thank you. And then again, we would kind of keep this updated. Next slide. And then here's a different example. So I intentionally on the first example left trauma blank, because a lot of times we're not going to have a relationship with someone where we actually can ask them about any history of trauma. And often that will kind of come up as you build a relationship with someone. So obviously, like a wide range of how the social history summary can look for different people depending on what's happening for them. Next slide. So then thinking about interventions, there's obviously a wide swath of what this can look like. For me, I'm always very attentive to the I, because income, as we know, is the #1 social determinant of health, and also because we in primary care are often put in the place of being the gatekeeper for many different interventions. So, constantly asking people if they're assessing if people might be eligible for OW or ODSP, helping them complete forms, like I said, for special diet and transportation. And then currently recommending basically lots of people apply for the disability tax credit if they're on ODSP, because of the new Canada Disability Benefit that's been created. But we're basically out of time, so we can talk more about what the different interventions are. Just next slide. Take a quick look. And then the next slide. So there's lots out there. We're so lucky to be working amongst lots of people that are doing great work in the community. And I think, primary care really can't do attachment on its own. We need to be supporting the community in the beautiful model that Jennifer laid out. And I'm happy to talk more about that today. Thank you.
Thank you so much. I love the way you talk about your practice and how you serve your clients. That was really inspiring. So now we're going to pass the mic over to Allison Hewitt, who is a registered nurse at Centretown Community Health Center, and we will bring your slides up.
Thanks, Natasha and Ritika. That was a beautiful presentation. I love it when I just I feel so on the same page with what you were saying. So thanks everybody for attending today. I'm here to talk a little bit about my practice. I work in inner city Ottawa at a community health center. And on the weekends, I also work in the emergency department, working with geriatric clients, trying to help them get home and stay home safely. So I'll be talking about mostly my practice, though, at Centretown. Can you change the slide, please? Thank you. So just a little bit about Centretown Community Health Center. It's been active since 1969, and we're so fortunate because we have this beautiful, massive team, multidisciplinary doctors, nurses, nurse practitioners, counselors, early years programs, dietitians, foot care specialists, you name it. We often have it, and then just a tremendous harm reduction volunteers as well. In terms of our seniors outreach program, we've been active at the center for the last 50 years. So we definitely have a culture here of going to where our clients are. And this is helpful, particularly for geriatric clients, because many of them are housebound. Change the slide, please. We can skip this. I'm kind of going to bounce around. Thanks. Who do we serve? So the WHO names people over the age of 60 as geriatric clients, but for our purposes, we see clients above the age of 65 years. This is for many reasons, but one of them is definitely just the size of our team. It's not very big. And because we're in inner city downtown Ottawa, there's a high density of seniors here. So we try to spread ourselves as best we can. Often, many of the clients who we work with are alone and isolated. I believe the recent stats said something like 49% of seniors live alone in the downtown core of Ottawa. They seem to lack support network, like family, like oftentimes there'll be, a random neighbor who's involved, or, somebody who's also getting something from the senior in order for them to do something for the senior. Our clients often have chronic illnesses, a panoply, I would say. Some of them visit the emergency department often, and others never ever want to go to the emergency department. And you can read the rest of the list. People who refer to us can be anybody and everybody. People can walk in and ask to be followed by the team. Physicians, we're directly linked with the geriatric unit at the Civic Hospital as well. So anyone who's in our catchment, they'll refer to us. There's a senior center downtown. We receive referrals from them. You can change the slide, please. So how are we integrated at the health center? All of the healthcare providers at our community health center do have the capacity to do home visits. in their schedule, although we do have 2 nurse practitioners and a GP that are are very specific providers who will regularly intake clients who don't have family physicians. Also at the center, we have like exercise programs, lots of seniors coming in for chair exercises, walking, cultural clubs, or sort of more low barrier health promotion, coffee connections, where you can just show up and have a cup of coffee and maybe chat with somebody or not. Foot care is free here as well for our clients. There's mental health services, individual or group counseling, ability to do counseling over the phone or virtually for those people that are housebound, and plenty of volunteer activities. Next slide, please. So this is our beautiful team. As I said, it's not enormous compared to the need out there. There are 3 nurses, 1 health systems navigator and outreach worker. She's a social worker by trade, but she's got a big fancy title. And then 2 nurse practitioners and 1 doctor. And as I said, we get referrals internally, but also externally. So we will work with the providers at the health center, but we will also work with providers exterior of the health center whose clients fall within our catchment region. And as well, we do geriatric consults, little pop-ins if somebody's not quite sure if it's a geriatric concern or not. And so this is helpful. We do have a lot of specialized geriatric services in the city of Ottawa, hospital-based primarily, or services where specialists that the client doesn't know will come in and do a big old assessment. But as Ritika brought up, a lot of these clients are very fearful because they've been institutionalized, they have mental health, they have substance use, they've had trauma. And so it actually takes us a really long time to develop kind of a relationship of trust with them. Like there are some clients who I talk to them through a crack in their door, or I meet them in their lobby or in the park because that's where they feel safe. And so having some new giant assessment done is a big turnoff for them. And so kind of like little by little getting to know them on their terms with as much time as they can handle. Like for example, with Ritika's document with all the determinants of health, like we would never try to tackle that all at once. That would just be so overwhelming for any one of our clients. So just having the time and the space, to get to know them in their safe place, it can be very helpful. And as well, kind of like doing warm handovers as well. With some of the clients, trying to bring anybody new in is very challenging. And for example, we have one lady who's a survivor from residential school, and then she had some abusive relationships. And after she doesn't leave her house, but then her eyes started to fail. So after 5 years, she went with our community health navigator to get her eyes checked. So she left her house, and that was 5 years to get any health things done, besides some prescriptions that she was willing to start for her mental health when one of our nurse practitioners physically went to where she was in her dark room. So next slide, please. So these are just some of the guiding principles. I find that social prescribing is so, it fits in so well with geriatrics because, in geriatrics, as much as in any health, it's so important to kind of get to know the 360 person, or, kind of have a holistic sense of how it's going. In geriatrics, for example, there's a geriatrician in town, Frank Molnar, who came up with the 5 M's of geriatrics. And one of them is what matters most to you. That is a fundamental part of geriatrics. And it's something that we should be asking people before we send them for a battery of tests or assume what they want. As well, with geriatrics, we're always looking at ADLs and IADLs, which is basically, if you don't know, so ADLs are the essential tasks that a person needs to perform in the care of themselves: bathing, feeding themselves, toileting themselves. We're asking about how is that going, or with the instrumental activities, how are they managing their finances, their transportation, communication, housekeeping. These are questions that are asked all the time in geriatrics, and they're very easy ways in to do a little bit of social prescribing. And for me, social prescribing really, again, as Ritika pointed out, comes down to trust. Can you have a trusting relationship with another person? And every new person that gets brought in, be it a PSW to help you bathe, or somebody who talks to you and touches your feet and trims your nails, like that's a successful social prescribing as well as medical intervention, because they're having a safe, trusting relationship. Possibly their skin's also being cleaned. It meets multiple needs at once, which is why I kind of talk about like 360, three-dimensional. You never really want to be that one person that can save a client. You never want to be in that situation, because it's terrifying, and because some of these clients are so vulnerable. Just like with kids, keeping a senior home is, you need a village. You need them to trust more than just you and open this circle, so that, hopefully it's not just about trust, but they find a sense of purpose and they feel safe and all those other things too. These are just, as I said, guiding principles. And I think I might just end there. I will mention, Ritika had mentioned a tool for assessing determinants of health, and we've just started using one that came out of the University of Edmonton. It's the HAAI tool, and it was developed by a team, a senior center in inner city Edmonton for seniors, and it kind of assesses health and determinants of health all within one package. So it's quite a beautiful tool. And that's how I'll finish. Thanks for listening.
Thank you so much, Allison. I feel like I'm getting more and more moved and engaged and excited with each presenter. So thank you so much. And now we've heard from a physician and a nurse, and now let's hear from the leader positions. So I will invite Margo Reilly, who is the executive director at Windsor Family Health Team, to share a little bit about how social prescribing works at her center.
Hi, everyone. I'm very happy to be here. Thank you for the opportunity to speak today. From a leadership perspective, social prescribing has been something that I've been working on for a very long time. I would say probably around 5 to 6 years, in terms of creating the framework, creating a sustainable model that would work within our family health team. If you could go to the next slide, please. The Windsor Family Health Team, just as a very high level overview, we are a community family health team, and our physicians are salaried. We're part of the blended salary model. Also, we have, under our programming, we've divided it up into 2 programs. We have our family practice program, which is very similar to other family health teams, where we have 7 FTE physicians enrolling approximately 11,000 patients. It's an enrollment model. So our patients are mostly enrolled or rostered with the ministry, but we do have some attached patients that are not enrolled that we see from time to time. Then we have our Team Care Center program, and Team Care is designed to provide an interdisciplinary health team to solo physicians or physicians and other providers who otherwise would not have a team to refer to. It is a referral model, and it is very much like what Jen explained, a hub and spoke model. We have a number of unique programs within Team Care that is available to the whole community by referral for the most part, but we do have some self-referral programs, including our One Team Recovery program, which is an addictions or substance use program. We are a regional site for low back pain, rapid access clinic. We also facilitate a MINT memory clinic for both family practice and also Team Care. Additionally, we also work with we are part of the lower limb strategy, and so we offer that regional programming as well as a wound prevention and treatment clinic. So we have many different types of programs, but we have our interdisciplinary health providers all within the same roof. With Team Care, we provide, again, support to 180 physicians within the community. Next slide, please. So we do have goals that we've set at the Windsor Family Health Team for the social prescribing program. And you will note that number 1 is to address social determinants of health. And by addressing them, we connect patients and caregivers to social services in the community, typically through direct community referrals, through a telephone call, or through a referral pathway that's existing and embedded within our EMR. We also, another goal is to reduce the burden on our primary care team, to decrease emergency department visits. Additionally, to empower patients to take control of their health and well-being, provide care to vulnerable populations. We are an urban center, very close to the downtown. It's very, it's difficult to say, no, we're not going to treat very vulnerable patients. We treat everybody from cradle to grave, as they say. And so we also are an advocate for our patients throughout their journey, and they can lean on our social prescribing lead, which is our nurse health Team Care. And she has been an advocate for a number of our patients as we've integrated the program. Additionally, we want to decrease the overall stress of our healthcare system, but our team in general. And lastly, to create a sustainable model of care within our team, because as we know, securing additional funding isn't always an easy task. Next slide, please. Eligibility for the program is very simple. So it is available to all enrolled patients through our family practice program, and for patients of affiliated physicians in the community with our Team Care Center program. Patients can access the program through the self-referral pathway, also by a primary care provider. So the way that we have sustained this program is it's a joint responsibility. Everybody on the team is trained to provide referrals to patients to make the connections themselves. And when there is a need to access a little more specialized help or care, or a need for a form, or a need to provide a little bit more navigation within the system, then there's an internal referral to our health promoter who is specialized in social prescribing. And the program itself is designed to serve all patients attached to both of our programs. Okay, next slide, please. This is an example of the framework that's in alignment with our goals. When we do send referrals to this, the social prescribing link worker or health promoter, it's very simple. And we are finding that the strategy is working quite well, and it is, again, embedded in the culture and also in the frameworks of all of our programs. Next slide, please. I would ask the question, how can social prescribing work to attach primary to promote primary care attachment. So, you know, a lot of these comments have already been made by my colleagues, and I wanted to make note that the social prescription does multiply primary care's access to resources for patients and caregivers. And you'll notice I keep on including caregivers because this is a movement within our own team. We are recognizing that part of our care team are the caregivers. So we want to make sure that they're well supported and we connect them to the resources that they need in order to feel healthy and then be able to support their loved one or their friend or whomever they're caring for. Again, social prescriptions can be an internal referral to an IHP, maybe a team member who has a specialty in a certain area that perhaps other agencies or other team members don't have. And then there's also the external referral pathway to community agencies. And we have a number of programs and services within the Windsor area or the Windsor Essex area that we can connect to. We do lean on 211 whenever possible, and we have an internal referral process from our organization directly by an evacs to 211, and then they do commit to doing a follow through and attaching that patient to any service that they need, and especially highlighting those services that they were referred for. And then lastly, social prescription connects patients to services that address social determinants of health and support a holistic approach. And that is something that we're trying to do more and more, is that holistic approach and ensuring that we are supporting everybody within the family unit, but also supporting our team members so that they can feel successful, and it does reduce provider burnout and the number of supports that are outside of that provider responsibility as the most responsible provider, the better it is for that provider to access, or I should say provide those resources to more people. So everybody on our team has been trained or has been socialized to the concept of social prescribing, including our reception team. And if there is a person who comes in and says, you know, I need a connection to a specific service, then they are invited to provide that information to the patient so that it is equitable and we're as efficient as possible in serving that individual. Next slide, please. If you would indulge me, I'm going to read a quote by one of our physicians from our team. And I think this captures the essence of what social prescribing can do for a clinician from a clinician's lens. So I'll just read it right from the screen, and it says, as it pertains to the social prescribing program, I care for a large group of patients with a wide range of social demographics. I have found the social prescribing program helpful for patients across that spectrum. The program itself provides me with a link for patients to existing community programs and supports that either I may not be aware of or have a poor understanding of accessing. Indeed, these programs are often dynamic, influenced by funding that may change, and staying up to date with all of them is impossible as a primary care provider. A simple referral may be a request to link an elder with programs for physical and social well-being in their community. More complex referrals include helping non-English speaking or recent immigrant patients with a link to an appropriate program for food security, job security, and even housing. Other examples include helping vulnerable patients navigate the process of reacquiring their driver's license, accessing their benefits for counseling or other supports, or linking isolated family members with their substitute decision makers when I have made a new diagnosis of cognitive impairment. Overall, I find the program to be an essential bridge between the doctor-patient and the patient community. Far too often, we are hearing new community programs that are redundant to already existing ones. The social prescribing program allows us doctors to refer to a properly informed individual who has a good finger on the pulse of available programs, reducing or eliminating this redundancy and significantly lifting the weight on our already overburdened front desk staff. Next slide, please. In addition to what I've already shared, I did want to take a moment to highlight the need to collect metrics and outputs so that you can evaluate your program and you can then advocate for a position. For example, without data and measurement, then it's very difficult to advocate for those positions. And also you're measuring the success of your team and the success and how you are treating and caring for individuals who are in your service, right? So, or sorry, that you are serving, pardon me. So next slide, please. And I would be remiss if I didn't really focus on the collection of socio-demographic and race-based data as a key mechanism in assessing and understanding the patient population that every one of us serve. And they can be enrolled and unenrolled. We collect this data in both of our programs, again, because in teen care, those individuals are not enrolled to our family health team. They're enrolled to other primary care providers. We seek information and data from our patient and family advisory focus groups. We survey patients and stakeholders. We collect feedback from our staff. And of course, we connect to partners and establish community resources. Next slide, please. I wanted to leave you with a couple of quotes that, very recent quotes, and I find them heartwarming, and a lot of individuals don't realize that there are programs out there. And a few years ago, I was involved with one of the very few and new social prescribing research strategies. It was with McMaster University, and it was the Health Tapestry program. And that program was focused on social isolation and loneliness in seniors. And I learned a lot during that program because loneliness is, in my opinion, an epidemic right now. And I think this social prescribing does support that connectivity and helps individuals thrive in their communities. Okay, so thank you very much, everyone. I appreciate your time, and that's the end of my presentation.
Thank you so much to all of our panelists. I'm left with a feeling of I would love for one of my loved ones or one of my family members to be cared for by any of the people on this panel, because really the way you talk about it is really moving. So we have only 2 minutes left. I would love it if one of my colleagues could put our webinar evaluation in the chat. We also have a slide, so maybe we could bring a slide with a QR code, but we have one question. So maybe in our next 2 minutes, I see there's one question in the Q&A. And I think if I understand the question correctly, it's how do you talk about social prescribing for folks who believe social prescribing does not fit within the curative diagnostic healthcare model in Ontario. So some health professionals feel it will never be a part of our system. Any advice for those difficult conversations to help with engagement and support? Does anyone have the magic solution on our panel? Yeah, Allison?
I just like to discuss efficiency and effectiveness. In geriatrics, because clients have so many health issues, I see a lot of things being ordered that the client doesn't necessarily want or actually physically cannot get to. And so to me, utilizing social prescribing can improve efficacy of care plans, and from that, hopefully, improve health overall of clients. So decrease need for healthcare visits, possibly.
Yeah, and Margo, did you want to add to that?
I think that depending on the team, I think that a lot of the direction should come from leadership. I think that we have responsibilities as leaders within the health system. It is a privilege to run a family health team, and it's a publicly funded resource. And I feel that it's my responsibility to lead in that direction. So I think that many other leaders feel the same. And so we should be leading within our teams to have a preventative care framework or a program. And if it requires some extra support or an ability to incentivize in any way, then I think that is something that can be done within the team. I truly believe it's a leadership's responsibility to prioritize this initiative and create the supports needed so that primary care providers can add this to their portfolio, I guess, or their services.
Amazing. And I see we're at time, so I think we're going to have to wrap up there just with respect to everyone's time. I will be, if my colleagues can post the QR code for the evaluation for the webinar. And thank you to everyone for joining us today. And thank you to our amazing panel. I really feel charged and excited, and I'm going to be really energized as I continue through my day. So thank you so much for joining us today.